Good morning and welcome to our webinar, How We're Making Healthcare Better. So to start, I'd like to introduce myself and today's speakers. I'm Kelly Morris and I've spent 20 years working in the private medical insurance market, and in April last year I became responsible for 110 people at AXA PPP who look after our corporate relationships. I'm really pleased to be joined today also by our Interim Chief Medical Officer, Dr. Annabelle Bentley, who also joined AXA PPP in May last year. Annabelle, a doctor and a surgeon, trained at King's College London and has more than 15 years' experience in clinical leadership in both commissioning and provider organisations in independent healthcare, leading teams of 7 to 70 people. I'm also joined by Sarah Taylor. Sarah is our Head of Specialist and Practitioner Relations here at AXA PPP. She graduated as a physiotherapist from St Thomas's Hospital in 1988, and since then she's amassed almost 30 years' experience working in healthcare, both in the NHS, within private hospitals, occupational health, and more latterly within the insurance sector. She has a postgraduate diploma in sports and exercise physiotherapy. She spent 6 years working for Bupa Hospitals, where she was a senior manager at her local Bupa hospital. And at Surrey Police, she was instrumental in developing a programme of health and wellbeing services for both the frontline and the back office police staff. At AXA, she's responsible for leading our specialist and practitioner strategy, and as part of that role, she's tasked with developing initiatives that, through collaboration and insight with healthcare professionals, ensure the delivery of better quality healthcare for our members and our clients. So today's topic is making healthcare better. So why do we need to make healthcare better? What is the problem that we are trying to solve? The quote that you can see on this slide does a good job of summarising the challenge. Healthcare is constantly changing. New drugs, technology bring different ways of diagnosing conditions and delivering care. However, you could argue that this has always been the case. In developed societies, healthcare has always naturally evolved. I think what's different about the changes that we're seeing now is how rapid they are evolving, and how things like digital, artificial intelligence, and genomics, to name but a few, are changing the landscape quite dramatically. There's been a massive rise in telemedicine or telehealth, a way of monitoring and diagnosing conditions remotely. There are now over 325,000 mobile health apps available, and patients can be offered personalised cancer treatment based on their genetic makeup. So whilst progression of healthcare is clearly a good thing, it creates complexity, confusion. What works, what doesn't, what should we pay for, what is safe medicine? As an insurer and an administrator of healthcare plans, our clients rightly demand that we have these answers and that we can support their employees and their families to make the right choices. Speaking to clients also, there's a real concern about ensuring that their private medical benefits remain sustainable, and by that we mean affordable. So needing to understand what represents good value for money is critical to this. I'm now going to pass to Annabelle, who's talk about how AXA PPP are trying to tackle these initiatives in real time and make healthcare better for our customers. Annabelle, over to you.
Thank you, Kelly. What we need to look at is what problem are we trying to solve. One of the biggest challenges today is the population is getting older. With that comes a greater burden from chronic diseases. Alongside that, there are many more treatments, as Kelly mentioned earlier. The pace of innovation is staggering. New cancer treatments, new operations, robotics, all of these things give us great opportunities. There's an opportunity for our members to make sure that we make healthcare simpler for them. What we hear back is it's too complex, it's too difficult, it's not convenient. We believe we can make it a much better experience for our members. It's also important we help them get the best outcome possible. With both of these, we believe we can deliver much better value. And one of the important things is getting the right person to the right care at the right time. If we get all of this right, we know that we get the feedback from members that they had a better experience than they thought they would. We'll also show over time that they'll get a better outcome than they would have done otherwise. And we also want to show the value to the purchaser, the corporate or the individual member, that they're getting much better value for the premiums they're paying. So I'm sure some of you will have seen the kind of stories that are reported widely in the media. These are common and big problems that we set out to solve. So, for example, last year, there was a big study done by the British Medical Journal that looked at cancer drugs. So when cancer drugs are licensed, over the past few years or so, how many of those new drugs made a difference? How many of them helped people survive longer? You may be surprised to know that even when drugs are brought to the market and are licensed, this study showed that about half of them didn't actually help the person live longer. It didn't help them manage their symptoms better. So this is an area that we're actively looking at to make sure our members get access to the best drugs, drugs that offer them real promise, drugs that help them live longer and live better with cancer, not drugs that offer them false hope. It's also of benefit to the person buying the policy or the company, because we want to make sure we're spending money on things that really work and make a difference, not wasting money on drugs that don't make a difference. Another area that is a common issue is shoulder surgery and knee surgery. And you may have seen widespread reports around a big trial of shoulder surgery trying to tease out, where does this operation work best? Are the operations that are carried out unnecessarily wasteful care? This again is something we're working very closely in partnership with surgeons on to make sure we get access to the right treatment for patients. We want people to get access to physio when they need it, and to only have shoulder surgery when it's clinically necessary, and we don't put people at risk by offering them unnecessary surgery. Some of you may also be familiar with the person on this slide. This is a picture of Ian Patterson. There's been widespread reporting of the challenges the whole healthcare system faces when surgeons operate systematically, unnecessarily. What's interesting here is how we start to solve this problem for our members. Ian Patterson wasn't acting alone. He's part of a wider system, a system in the NHS, a system in the private sector, where there are clinical governance mechanisms. What we're doing on behalf of AXA PPP members is making sure that when they get access to surgery, are treated in hospitals, we're working in partnership with hospital directors and doctor representatives to try and tackle some of these problems, make sure we have the right reporting systems for our members, and make sure we don't expose them to surgeons where they have a much higher risk of operating, and some of those operations may be unnecessary. This is a win-win-win. It's much better for members to make sure that they're seen by surgeons who make appropriate decisions and offer patients a wide range of treatment. It's better for doctors because they have a good, constructive working relationship with us. It's also better for the people who buy the policy. It's much better value to make sure you see surgeons who work as part of a team and offer a wide range of treatment, because overall it will be better value spend. What it's also useful to think about is an issue from the past. When we first started to look at overuse of certain treatment, the lessons of history are also useful here. In the past, tonsillectomy was a very commonly carried out operation. I'm sure some of you listening will be able to think back in your own family. Think of children now. Far fewer children go through that rite of passage of having their tonsils out. Whereas if you look back 20, 30 years ago, this was a commonly carried out operation. Those surgeons are still in practice today. So one of our questions is, what is it now that we'll look back in 20, 30 years and think, that was really a very overused operation? And having considered that, what things can we do now? This is what AXA PPP is actively looking at. These are the problems we're solving. We're looking at knee arthroscopy, we're looking at spinal surgery, to try and determine where are the most useful cases, and if there are any clinically unnecessary procedures, we don't fund those anymore. Again, this is in the best interest of the patient and the person paying for the service. Finally, I'd like to touch on what makes AXA PPP different. Because of our size and scale, the amount of data we have, the insight and analytics we're able to bring, this means we're able to detect where some of the biggest challenges are, but also where some of the biggest opportunities are. Another point of difference is how we work with our partners. We work very closely with doctors to make sure it's a constructive working relationship and we're both trying to achieve the same things. Similarly with hospitals, the ideal is we all want to work together on the most efficient pathway that benefits everybody. So to give you some examples, we're spending around £1.1 billion every year on healthcare treatments for our members. We're changing how we manage that money by making sure that our members get to see the best value specialists. I'd now like to hand over to Sarah, who'll talk to us a little bit more about exactly how this works.
Thank you, Annabelle. I think you can hear from both Kelly and Annabelle that we take our responsibility for the people whose health we cover seriously. And both Kelly and Annabelle have talked about how we are striving to achieve better health outcomes, a better experience and better value care for our members. But how are we doing that? There are two ways in which we can deliver those three core pillars. One is to engage differently with the specialists and the practitioners who deliver care to our members. After all, it is to them that our patients turn when they have a problem. Annabelle has already mentioned how we're using our data differently, how we're helping to track variation and understand why the treatments that some specialists deliver are very different from others. But we're not using that data unwisely. We're discussing it with specialists to help us all understand how we can improve care and value that we deliver to our members. Not just value in terms of the money, but value in terms of the outcome and the individual gain that that patient gets from that healthcare experience. The second way in which we can help deliver these three elements are to change the way in which we engage with the individuals who we look after. So we're looking at how we can provide our members with better information and tools to help them make more informed choices about the healthcare decisions they make. And we're doing this through web resources and through the guidance and support of our staff. So what have we been doing to make healthcare better? To get people to the right person for the right care at the right time. And there are a different number of ways we've been doing this in different areas of medicine. You will all be familiar with our working body pathway, which allows direct access for our customers who have musculoskeletal problems and allows them to get to treatment as quickly as possible. That treatment might be a management program that they take on themselves. It might be access to physiotherapy. It might be imaging, or it might be referral to a specialist. We have taken the same path with management of mental health disorders, a problem that I know is top of the mind for all of you. How do we get direct access to a risk-based assessment that allows our members to choose the most appropriate path for them and gets them on the road to recovery as quickly as possible? Finally, we've put in place our Doctor at Hand service, allowing people to have access to a GP as quickly as possible who can offer them help and support in the next steps of their pathway. What I'd like to do now is to give you an example of how we are making healthcare better. We're taking each clinical area and looking at how we can understand how we can better support our members in making the right choice about their healthcare. Annabelle has already mentioned the work that we've been doing with knee arthroscopy. It has long been clear from evidence that arthroscopic knee surgery in patients with osteoarthritis of the knee is an inappropriate operation and does not deliver benefit for our members. There is a risk associated with all surgery, and we believe it's important that patients are offered the choice of treatment that meets their needs best. So we are now offering access to a brace which has been proven to deliver benefit for patients that have osteoarthritis of the knee. And we are also looking at a second opinion service where a member is able to speak to a surgeon to enable them to understand the procedure for which they're being referred. But we are not stopping there. We see our journey into managing healthcare better and improving healthcare outcomes for our members as an evolving story. We will take medicine condition by condition and find ways in which we can support our members, always focusing on improving member experience, delivering better outcomes for them, and value both for them and for the purchasers of healthcare.
So here is an example of how we are making a difference. I'm going to use knees as an example. In fact, knees are a great place to start. Not only do they cause problems for many people, but arthroscopic knee surgery is one of the highest volume procedures that we fund. Looking back at 2015, we paid out around £20 million in claims for knee arthroscopies. Half of these claims were for individuals over the age of 50. We know that at this stage in life, we would expect to see some wear and tear around this joint, and clinical wisdom suggests that when we reach this age, there is limited clinical benefit for this treatment. Sometimes it might be appropriate, but careful selection is required before offering it as a treatment in this group of patients. Our data showed us that there was considerable variation in operating rates. That's the numbers of operations being performed between specialists. From this, we identified a number of specialists that had a higher propensity to perform arthroscopies. Once identified, we were able to engage with them individually so that we could understand what was driving this difference. In the last year, we've paid around £15 million in knee arthroscopies, a reduction of 25% in value. There are various reasons for this, and we can't take full credit, as we've seen an overall drop in the number of arthroscopies performed, as more specialists have become aware of the increasingly compelling research. However, our targeted approach has, we believe, contributed to a reduction in variation, and a year-on-year growth in the use of pathways has delivered a reduction in incidence of this operation, and therefore a reduction in overall cost. In addition, we reviewed all our specialists based on the advice from our knee panel, and have proactively started to direct our members to those specialists who have a high volume knee practice, who have low conversion rates to surgery in this age group, who are able to perform complex knee operations, and who overall deliver value, as demonstrated through the episode costs of care that we see. This demonstrates good value. Unnecessary servicing of patients is not good for the patient or for the funder. In the last year, we've seen around 53,000 musculoskeletal cases, of which 7,300 are knee-related. For our large corporate clients, we've seen an increase year on year in use of the working body pathway, where the employee doesn't need to go to the GP for a referral in order to start receiving advice and treatment. In fact, around a third of the 7,300 cases go through this pathway. Our member research on the pathway shows that individuals value the guidance and support that this service provides. So our data is helping us recognise and act on trends. Our closer engagement with the medical profession is helping us to understand better what good care looks like, and enabling us to engage with providers differently and inform best practice. By working in this way, we are better able to understand changes in treatment, and we're well placed to offer the kind of advice and support that helps reassure our members at times that can be stressful and sometimes frightening.
So what was yesterday? Yesterday was working body, stronger mind, doctor at hand. Today sees us offering bracing for customers with osteoarthritis of the knee. It sees us allowing direct access for patients who have concerns over skin lesions or indeed into the future breast cancer. And then in the future, from 2019 onwards, we will be looking at how we can support individuals who've got concerns over prostate cancer. But what are we looking at in the future? how do we ensure that members get access to the best possible pathway for them? We're looking at evolving our musculoskeletal pathways, taking into account changes in clinical practice. And we're looking at how we can better diagnose and support patients who are at risk of developing colorectal cancer. So what I'd like to do now is to hand you over to Kelly for her to explain how we are making healthcare better for our customers.
Thank you, Sarah. So as Sarah said, I want to sort of move on now to explain some of the resources and teams that we have available to support members on making better decisions around their healthcare. Some of these have been around for quite a long time, some of them have evolved recently, and some are brand new. So our nurse case management team are a well-established team service offering dedicated support to our members when they are claiming for complex or costly medical conditions. We also have our online health centres, which cover a range of conditions from heart, cancer, musculoskeletal, pregnancy and childcare, to name but a few. These online resource centres offer up-to-date and clinically robust information to help our members and their families become more informed about their medical condition. In the Cancer Centre, for example, they can access live chats with our clinical experts on things like prostate cancer, chemotherapy regimes, bowel cancer. There's also some really good resources for employers too, such as how to talk to one of your employees when they're diagnosed with cancer. In the Musculoskeletal Centre, there's advice on treating sports injuries, how to cope with arthritis, to name a few topics. Our Health at Hand service, available 24/7, gives your members direct access to nurses, pharmacists, midwives to answer any health question. They specialise in family health and they have expert knowledge of physical, psychological and behavioural conditions and can provide support and guidance on up-and-coming operations, worries about your children and all relatives. Sarah's already mentioned our Second Opinion service. It's actually been around since about 2013, but as Sarah's alluded to, we're starting to focus our Second Opinion service on some very specific sort of areas. Sometimes it can be really invaluable to have a Second Opinion service, giving you peace of mind and reassurance when you need it. And it's designed to make sure that you're completely confident with your specialist recommendations. It's available on all appointments covered by your plan, and AXA PPP will pay for any related costs, such as the first appointment with the new specialist and any new tests that might be required. So that it doesn't disadvantage any of our members who might be on a plan that has a voluntary excess or a no claims discount or might have an outpatient limit, we will not apply these terms in respect of any Second Opinion service. It's important that members have access to it without being penalised through their plan limit. And finally, I'm delighted to talk about a new initiative from AXA PPP called Health Unlocked. This is I suppose, an organisational reform we came across through our sponsorship of the Health Tech and You Awards. They were the winner in 2017. They're basically a social network for health. So by finding others with similar healthcare backgrounds, your members can sort of come together within a forum and talk about their day-to-day health concerns together. We're bringing it to all of our members free of charge to provide them with support and guidance they need to make informed decisions about their health. It offers a peer-to-peer support network for patients, caregivers and healthcare advocates, connects safely online with guidance from credible organisations, charities and institutions. It's the biggest network for advocates in the world. 500 patient advocacy organisations are on the community, and members can talk about their experience of conditions, symptoms, and be signposted to relevant content. In terms of sort of user experience, researchers found that 91% of people using Health Unlocked found it really useful or life-changing, and 97% felt more confident when speaking to professionals as a result of using the site. And it obviously complements some of the existing online health centres that I've talked about. So moving on really to summarise why AXA PPP are here to make healthcare better and how we're doing it. I thought it'd be useful to summarise the 5 ways that we're doing this. So firstly, it's through our continued evolution of care pathways that Sarah talked about, improving patient experience, providing direct access to the appropriate clinicians in the right place at the right time. Also by offering alternative treatment options such as the brace that Sarah talked about, and access to clinicians and providers that can provide the most effective and fast access to appropriate treatment, so whether that's online resources, in-person physio, etc. Also through our second opinion service, which I've talked about, and also by offering member support throughout their claims journey, empowering them, whether that's through the advocacy of our nurse case management team or via the resources like Health Unlocked and our online centres. Finally, by making sure that our members get access to the right doctors, by giving them access to those that operate within certain best practice guidelines. And indeed, I was sort of reading at the weekend, I think it was on the Times, again, going back to some of those sort of media reports that Annabelle alluded to, about, psychiatrists taking referral fees for referrals to quite expensive clinics. So it's making sure that when we arrange treatment for our members on your behalf, that you can be assured that we've done the homework, the background research on which are the right ones, which are going to operate within the best clinical guidelines and deliver also the best outcome for your members. So that hopefully summarises some of the initiatives that AXA PPP are deploying to make healthcare better. And ultimately, it's about delivering a better member experience, better healthcare outcomes, and knowing that we do that, delivering good value as well. So now moving on to any questions that you may have. So we've had a question that's come in here about how we manage employees who want to see a specialist that might not be on our sort of preferred or approved list. Sarah, I wonder if you could answer that for us.
Yes, of course, Kelly. We only recognise specialists with significant experience as NHS consultants whose high clinical and ethical standards we trust. This is so important that we have a 30-strong provider audit and investigations team dedicated to ensuring that these standards are maintained. We examine all causes for concern, such as member complaints, unexplained billing, or variation and possible medical negligence. We focus only on relevant data for the specialty and subject the results to clinical scrutiny. Occasionally, we do de-recognise specialists for clinical or commercial reasons, but to put this into perspective, we de-recognise less than 0.5% of the circa 23,000 specialists that we recognise. In the main, we follow the GMC register when a specialist is suspended or struck off. We suspend or de-recognise specialists only after a thorough process of investigation, analysis, and discussion with the clinician in question.
We've also had another question that's come in, which is around what informs us, or what drivers do you have to decide which areas of medicine or conditions to focus on? And again, Sarah, I wonder if you could answer that.
Yes, where we focus our attention are in those areas where emerging clinical evidence suggests that the old ways are perhaps not the best and are not delivering the best outcome for patients. So we've looked at arthroscopic surgery, as you heard both Annabelle and I explain, and that includes both the hip and the shoulder along with the knee. But we'll also be looking at certain treatments for atrial fibrillation, where again, emerging evidence is suggesting that patients should be given information on how their treatment is managed better.
Okay, we've had one final question now, and I'll just read it out. We have a self-funded medical plan, not administered by AXA PPP, and we do have members on this that want to see specialists that aren't on an approved list. What would AXA's approach be to covering those specialists? And Annabelle, I wonder if you wouldn't mind taking that question.
Thank you. I think that's an important question. This really gets to the heart of who's making the choice. At AXA PPP, we believe the member and the person paying for the scheme should ultimately have that choice. How we're different is we use our data to select a range of appropriate specialists and offer those to a member. There might be some occasions where that person says, I hear what you're saying, these are good specialists, I would like to see someone different, and I'm prepared to pay a top-up fee. Our approach is we respect that choice and give members that option.
Thanks, Annabelle. And I also know from experience of working with some of our clients, particularly where it's a self-funded plan within a trust, that we do have some trustees that will allow access to those specialists that perhaps aren't on our preferred list. So there's also flexibility, I suppose, within your plan design as well in terms of what you might want to cover. Thank you, Annabelle. That was great. Okay, so I think that concludes our Q&A section. That's all we've got time for today. Thank you so much for all of your questions that are coming through. Thanks all for your time today. I hope you found it useful. Thanks very much. Bye.